Welcome. We'll be talking about mechanical ventilation. And this is a very important topic to have at least a basic understanding of, especially since almost all, if not all, of our patients will be ventilated for some period of time, hopefully less than about 6 hours, although certainly we have patients who do tend to linger on the vent and have more complicated courses. And having a basic understanding of the ventilator and its modes of ventilation and some practice around it can be very helpful in your ICU care of your cardiovascular patient. And that is the basic goal of this lecture, to give you a solid foundation from which to work with. Mechanical ventilation. Before we start our in-depth discussion on mechanical ventilation, it is first important to establish a common language, and we will do this through the exploration of basic pulmonary physiology and the establishment of a common language that we will be using throughout the rest of the lecture. On this slide, you see a complete breath pattern. On the x-axis, you can see different phases of respiration. We have inspiration, an inspiratory pause, and expiration. And on the y-axis is pressure in centimeters of water. If we have a patient take a breath, we'll see that as the volume increases in their chest during their inspiration, their pressure is going to go up. And it's going to reach a maximal point, which is your peak inspiratory pressure. As you breathe in, you reach a maximal point. And the pressure during this inspiratory phase, there's two present. You have resistance and compliance. And the resistance is the resistance of air moving through the airways, and the compliance is the distension of the lung tissue itself. If I then perform what's called an inspiratory pause, you will find that the pressure drops and you end up with an inspiratory plateau. Because I am holding my breath and air is not moving, there is no resistance to air movement. As a result, resistance fades away and you are left with what is representing just compliance, or compliance isolated. And therefore, if you look at the difference between your peak inspiratory pressure and your inspiratory plateau pressure, your PIP minus your IPP, should give you, or should represent, the resistance by itself. If I then exhale, again, there's two forces present, resistance and compliance. However, this time compliance is working in your favor because your chest, because of the elastic recoil properties, it's trying to return to its relaxed state. So it's helping push the air out rather than fighting against it as it expands. If you then hold your breath at the end by performing an expiratory pause, in theory, you should have an airway pressure of 0. Now, there are residual volumes and pressures associated with them, but it is as close to 0 as we can get. And this is why when we measure our hemodynamic measurements, we do so at end expiration. It's because we don't want our numbers polluted by the pressures associated with our pulmonary pressures from our thoracic cavity. We don't want to see this resistance and this compliance affected, and the result of our inspiratory plateau pressure and our peak inspiratory pressure showing up on our hemodynamics. And you can look, when you look at your hemodynamic tracing, you'll notice that the overall trend goes up, down, up, down, up, down. When you have a patient who is spontaneously breathing, the inspiration is a negative inspiratory process, and expiration would be positive. When you are mechanically ventilated, it is the reverse. Inspiration is going to be a positive process, and expiration would be negative. So just remember, determining where inspiration and expiration is depends on whether you're mechanically ventilated or not. However, regardless of whether you're mechanically ventilating or not, lowest pressure will always be associated with end expiration. We will discuss the two concepts of compliance and resistance in detail, and we will start with compliance. Compliance determines the gas volume in the lungs when under pressure. There are three factors that contribute to the physiology of compliance, and those are distensibility, stiffness, and elastic recoil. Distensibility represents the degree of possible inflation, and it relates to the population of elastin fibers within the lungs. Stiffness is the resistance to the stretch, and it is related to the population of collagen fibers within the lungs. Elastic recoil is the ability of the airways to return to their deflated position. The three factors that contribute to compliance are your distensibility, your stiffness, and your elastic recoil. And again, think of it like rubber bands. Some rubber bands you could take from a resting state and stretch this far, and some you can stretch even further. This one would have greater distensibility than this one from a same resting state. Some rubber bands are relatively thin, and some rubber bands are very thick. And while the thin one is probably very easy to stretch to this endpoint, this thick one probably takes a lot more strength to stretch to that same endpoint. And so this would be stiffness. So we have distensibility as a concept and stiffness as a concept. And elastic recoil is the inherent desire of the tissue to return to its resting state. So if you have a rubber band and you stretch it out, it's going to come back to its resting state. If you have, let's say, a spring and you do so with it, here's its resting state. Let's say we stretch it to about here. It's going to spring back, okay? But there is a point when you break the spring and it loses its elastic recoil, right? And so that sort of kind of demonstrates the concept. But your lungs are like the spring moving back and forth between a short distance. They want to spring back to their resting position. They have this inherent quality, and it's based upon the collagen and elastin fiber densities and populations within the lung. There are also parts of the ventilator circuit that contributes to the compliance within the circuit, and these factors would be PEEP, any connector tubing, and also the patient's chest wall can relate to compliance. Specifically, if the patient has chest wall rigidity due to pain or splinting, or if the patient has a burn with significant eschar, limiting their chest wall distensibility and movement. There is a physics formula that explains compliance within the lung tissue, and it is Laplace's law. And it states that the alveolar pressure is equal to 2 times the surface tension divided by the radius. And while this is interesting to understand, it is not practical to measure the radius of each alveoli. So there is a clinical formula that represents compliance, and it is that the thoracic compliance, C, is equal to the tidal volume divided by the inspiratory plateau pressure, where the tidal volume is the numerator, the inspiratory plateau pressure is the denominator, and compliance is the quotient. As compliance decreases, alveolar pressures will increase for a same lung volume. Thoracic compliance is a measurement of pulmonary illness severity. So in the example of a patient who has a pneumonia and has an identifiable consolidation on their chest x-ray, antibiotics, nebulizers, and good pulmonary toilets are instituted, the patient will tend to improve prior to the radiologic consolidation resolving. A way to assess the patient's response to therapy is to look at the compliance of their lungs each day as they're on the ventilator. And with the resolution of the stiffness within the tissue as the pneumonia resolves, the lung compliance should improve, and this should be observed. Putting this clinical formula into practice, we can take 2 examples, one showing normal static compliance and one showing compliance in a lung with active pathology. If we take our formula, compliance equaling the tidal volume divided by the inspiratory plateau pressure minus the PEEP, and we plug in normal values such that the tidal volume is 800 cc's, the inspiratory plateau pressure is 15, and the PEEP is at 5. Mathematically, it would resolve to a compliance of 80 milliliters per centimeter of water, and this would represent a normal compliance level. If we then take all of the same numbers, except we increase the inspiratory plateau pressure such that it represents a plateau pressure of a patient with active pathology, we will see for the same 800 cc tidal volume, if the plateau pressure is 45 minus 5 of PEEP, the compliance drops dramatically to 20 milliliters per centimeter of water. Through the use of this formula, we can also demonstrate how people increase lung compliance. If we take the lower example, and instead of applying 5 centimeters of water per peak, we apply 15, the denominator would be 30 instead of 40, which would divide into the numerator of 800 cc's more times and give you a higher number for your compliance. Resistance determines the inspiratory pressure needed to achieve a specific inspiratory and expiratory flow rate. And similar to compliance, there are 3 factors that contribute to resistance physiology. Airway radius is the most important, and this includes the transmitting and respiratory airways. Air viscosity, which is often not considered. Most patients are breathing room air or room air with a mixture of varying degrees of oxygen up to 100% oxygen. The difference in viscosities between room air, the various levels of admixture, and 100% oxygen is negligible. This only really becomes important in patients who have severe asthma, such that the airway resistance is very extreme. Some patients will be treated with Heliox, which is a mixture of helium and oxygen. Keep in mind, room air is mainly nitrogen, and nitrogen and oxygen are relatively close on the periodic table. Helium, however, is a much smaller molecule, and when mixed with oxygen will lower the viscosity significantly. Inspiratory flow rate, which represents the rate of air movement, is also important. At lower flow rates, airflow tends to be more laminar, straight lines. As the flow rate increases, the central portion will tend to remain laminar. However, the outer portions closer to the wall of the airway will become progressively more turbulent and will increase friction and resistance to air movement. Ventilator tubing also contributes to airway resistance, and it is important to keep in mind that the alveoli themselves are excluded from resistance pressures and do not contribute to it. Again, there is a physics formula that can represent airway resistance, and again, it is not practical to apply clinically. However, it is important to understand. Resistance equals 1 divided by the radius to the 4th power, which means that small changes in the airway radius will be amplified and create exponential changes in airway resistance. This is why the difference between a 7.5 or an 8 ET tube can represent a large difference in the ease of ventilating a patient. Because it is not practical or possible to measure all the various airways within your respiratory system to figure out the radius, there is a clinical formula once again, and that is airway resistance R is equal to the peak inspiratory pressure minus the inspiratory plateau pressure divided by the inspiratory flow rate. And remember, your peak pressure represents resistance and compliance, and your inspiratory plateau pressure represents compliance. The difference between the two represents measured resistance. As airway resistance increases, airway pressures increase. And pulmonary resistance is a measure of airway illness severity. So a patient who has bronchospasm and has increased airway resistance, if this patient is given a bronchodilator, and subsequently if their resistance improves, the bronchodilator has worked. However, if the resistance has not improved, then the bronchodilator has not been an effective therapy for that particular patient, and a different therapy may be indicated. Again, we will take resistance and look at it in 2 scenarios, one with a normal airway resistance and one representing airway resistance that has undergone bronchospasm. If we plug in normal numbers for our first scenario, we have a peak inspiratory pressure of 25 and an inspiratory plateau pressure of 22 and an inspiratory flow rate of 0.5 centimeters of water per liter per second. We find our airway resistance is 8 centimeters of water per liter per second. In a patient with bronchospasm, if we use all the same numbers, however, we increase our peak inspiratory pressure significantly up to 42, we find that our airway resistance increases to 40 centimeters of water per liter per second. Having established some basic common language and pulmonary physiology, we can start to talk about its application and modes of ventilation specifically. A mode of ventilation is a set of rules which the patient will be ventilated by. And each mode is governed by components or characteristics, breath types, breath scenarios, and rate. Each of these represents an aspect of a mode of ventilation, and when summed together represent a specific mode. We will first talk about the different choices within each category. Once we have done so, we will then mix and match from each category to build different modes and discuss the clinical application. The first aspect of mechanical ventilation we need to discuss are breath types, and there are 3 common breath types: volume cycle breath types, time cycle breath types, and flow cycle breath types. Volume cycle breath types, basically the word cycled means a variable that terminates inspiration. So for a volume cycle breath type, what you're saying is that we are going to set a specific volume, and once that volume has been achieved, that will be the variable that indicates the timing of the termination of inspiration. A usual adult volume for ventilation will be between about 5 to 8 cc's per kilogram. You will find sometimes patients need more, and sometimes with patients who have lung injuries, you may ventilate them less, 3 to 5 cc's per kilogram sometimes. Volume cycle breath types are good because you are guaranteed to get a specific volume and guaranteed to ventilate them a reliable amount. Remember though, compliance is equal to volume divided by pressure. And for a patient that has a specific lung compliance, if you maintain volume, pressure will vary as their compliance changes. So while you are guaranteed to have a specific volume, you run the risk of having volutrauma or barotrauma. Whether or not you have a lung volume that is set that is too large for the lungs, such that it generates a large pressure and injury, or if you have a normal physiologic volume, but because of the patient's altered compliance, a large pressure is brought about as well. This can lead to pneumothoraces, pneumomediastinum, or lung injuries to the alveoli themselves. The reciprocal choice to volume cycle breath types is time cycle breath types. And really, time cycle breath types should be called time cycle pressure limited breath types. And this means that a breath will be given, and it will be given for a set amount of time. Once that time is up, then inspiration is terminated. This is done in the presence of a pressure limit, such that if a breath is set to be given over 1 second, a patient with greater compliance would be able to tolerate a larger volume and still stay below the pressure limit, whereas a patient with poor compliance may reach the pressure limit very early and end up with a very small volume. So the risk with time cycle ventilation is hypoventilation. Here, you are guaranteed to be below a set pressure that you choose so that you can have a protected pulmonary system and have little risk of barotrauma or volutrauma. However, you are not guaranteed ventilation. So the choice is between really the two, volume cycled or time cycled. Do you want to have a guaranteed volume with a variable pressure, which puts patients at risk for injury, or do you want to have a guaranteed pressure and by doing so ensure patient safety, but have a variable volume and run the risk of hypoventilation? And so a quick word about compliance. And remember, compliance is equal to your volume divided by pressure. So for a given volume, for a set volume, right, 400 cc's, 800 cc's, whatever we select for this example, all right, depending on what the compliance is, I'm going to generate different pressures. So if I have nice healthy lungs, my pressure is probably going to be pretty low, in which case a smaller denominator goes into a static numerator more times, you end up with a larger quotient, you end up with greater compliance. So greater compliance is seen by low pressures associated with the volume. Now, if I have that same volume, but my compliance is very poor, you're going to see that the pressure for that same unit of volume is going to be much higher, right? Instead of having nice give, relaxed lungs expanding, not a lot of pressure, you have very tight pressure building up because the lungs are stiffer and less distensible. As a result, this larger denominator goes into the numerator less times, I have a smaller quotient. So a lower compliance is associated with higher pressures for the same unit of volume. And when you are mechanically ventilating patients, you have a choice. Do I want to keep my volume as a certainty, or do I want to keep my pressure as a certainty? So when you are in a volume cycle breath type, your volume is what's constant. As a result, your pressure is variable, right? And it's variable based upon breath to breath and resistance within the chest, synchrony on the vent, amount of compliance within the tissue, all of these different things. Because your volume's constant and the pressure is variable, you run the risk of injury, you run the risk of barotrauma, you run the risk of volume trauma. And that's the trade-off. You get certainty in ventilation, you have uncertainty in safety. Now, some people want it the other way. They want to have pressure as their constant and volume as what's variable. And in this situation, you set a pressure limit such that the rules of the game are that I'm going to give a breath over 10 seconds, but this is the pressure limit. And so the pressure won't go above that. You don't have the same risk of barotrauma and volume trauma. But what's going to happen is, as the lung compliance goes down, if your pressure is what's held constant, then your volume is going to go down. So your variability comes in the volume, and you run the risk of hypoventilation. So certainty in ventilation, risk in pressure, certainty in pressure, risk in ventilation. And that's the trade-off, and that's the choice, and it's a stylistic, training type influenced paradigm, whether or not you prefer volume control or pressure control. If you put yourself on a ventilator and try breathing, I would say that pressure control probably is a little bit more comfortable, a little bit more natural feeling. Probably pressure support is the most natural that you can feel on a ventilator as far as the different modes of ventilation and what they feel like. Flow cycle breath types are unique, and they're only used in one mode of ventilation, and we will discuss them when we reach that mode. But for the most part, you should know that your choice is a guaranteed volume with a variable pressure, or a guaranteed pressure with a variable volume. Breath scenarios, there are two main categories and three types of breath scenarios. You can have spontaneous or mandatory. And spontaneous basically means that the patient is breathing unassisted. This is the mode of ventilation which requires the most work. The patient initiates inspiration and the patient terminates inspiration. And we talk about inspiration only because by doing so, we by default talk about expiration. So the termination of inspiration is the beginning of expiration, and the initiation of inspiration is the termination of expiration. So by actively talking about inspiration, we passively talk about expiration. So in spontaneous breathing, the patient is starting and stopping, they're doing all the work. The other types of breath scenarios are mandatory. You can have assisted or controlled. And assisted means that the patient's doing some of the work. They're initiating the breath, but then once the ventilator senses that the patient is initiating it, it takes over and will deliver the breath. And the ventilator will determine when the breath stops. And the question is, how does it determine when to stop giving the breath? The answer is by the type of breath type that you choose. So if you choose a volume cycle breath type, it will terminate inspiration when a specific volume is reached. If you choose time cycled, it will terminate inspiration after a specific time has elapsed in the presence of a pressure limit. Controlled breaths mean that the ventilator or the machine will start inspiration and the ventilator will stop inspiration. So this is the lowest work mode, or a no work mode for the patient, at least, mode of ventilation. And we know already, how does the machine know when to terminate inspiration? It does so by the breath type that you set. In this mode, the machine is also determining when inspiration starts. And the question is, how does it determine that? The answer is that it determines it by the rate that you set, which is the next characteristic that we will talk about that contributes to modes. And on the bottom, we have graphics which represent each type of breath scenario. First on the left, we see spontaneous or unassisted breathing, and this is what we're all doing right now if we are not on the ventilator. Inspiration is a negative inspiratory process, and expiration is a positive process. And you can see that the tidal volumes are relatively small, especially compared to the mechanically ventilated breaths, which we see next. The middle graphic shows us an assisted breath. There is a negative inspiratory trigger. The patient starts the breath. The machine senses this and then takes over and gives a positive pressure ventilated breath, a mechanically ventilated breath. And you can see an inspiratory and expiratory time for that. And again, it terminates its inspiration by the breath type rule that we set. On the far right, we see an example of controlled mechanical ventilation, which means that the patient is not generating a negative inspiratory trigger. The machine is starting the breath as well as stopping it, and it is doing so based upon the rate that we set. So for our rate, which is the last component that contributes to our modes of ventilation, we see that you can have a normal physiologic mode, which is around 12, and the patient's physiologic needs may vary depending on their clinical state. You can also have an intermittent rate, which means that a set rate on the ventilator is present. However, it is not sufficient in of itself to sustain physiologic homeostasis. And this may be a rate of 4, 6, 8, anything less than what a normal physiologic rate would be. And then you can set a rate of 0 or have what is called a patient-determined rate. And you don't set a rate, the patient breathes on their own and determines whatever rate they're going to breathe. From all of these varying options, we can start to pick and choose and put together and build modes. And the first mode that we'll talk about is what is commonly called assist control mechanical ventilation. And there are 3 rules that govern assist control, and each rule corresponds to one of the components of what a mode is. So in assist control, rule number 1 states that the set rate is the minimum number of breaths given per minute, and usually it is set at a normal physiologic rate. Now notice, this rule only discusses the minimum number of breaths. It does not talk about the maximum number of breaths. So if I set a rate of 12, I am guaranteed to get 12 breaths. However, if I hyperventilate or if I overbreathe, I will then get 14, 16, 18, 20, however many breaths I'm doing. So there's no limit on the maximum, however, there is a minimum number. The second rule is that all of the breath scenarios will be either assisted or controlled. And really, the rules of the mode is in the name. It's called assist control ventilation. There's no spontaneous breathing in this mode, which means that if I am not breathing at all, I'm going to get all controlled breaths. If I'm breathing somewhat intermittently, I may get some assisted breaths and some controlled breaths, but if I overbreathe the vent, I will not be able to have a spontaneous breath. The machine will interpret it as a trigger and will deliver a mechanically ventilated breath. Before the advent of assist control, controlled ventilation and assisted ventilation were separate modes, and they both have problems. In controlled ventilation, you would be guaranteed to ventilate the patient, and you would be guaranteed to do so at a specific rate. However, there would not be good compliance between the patient and the ventilator. And an issue arises if the patient is trying to breathe spontaneously. If the patient is trying to exhale when the machine is delivering a breath, poor synchrony and high pressures can result. In assisted ventilation, you will have better synchrony because the patient will be triggering each breath with a negative inspiratory trigger. However, if the patient becomes apneic, they will not trigger the breath and they will not be mechanically ventilated and will be apneic on the vent. By combining both of these aspects and having assist control, you can have the synchrony of assist, but have the backup of control in case the patient goes apneic. The third rule is that the breath types delivered for assist control can be either volume cycle breath types or time cycle breath types. If you use a volume cycle breath type, this type of assist control is commonly called volume control. And if you use a time cycle pressure limited breath type, this type of assist control is often called pressure control. You will sometimes encounter people incorrectly using assist control to be synonymous with volume control. And you will hear them say, oh, I'll change them from assist control to pressure control, which doesn't really make sense because pressure control already is a subset of assist control. In reality, volume control and pressure control are subsets of assist control. and they are determined by the breath type that you use. So 3 rules, one for each aspect of the mode, and the characteristics that chosen from the options generate the rules that govern the mode itself. And on the right, we can see an example of assist-controlled ventilation with some breaths being assisted, and this is denoted by their negative inspiratory triggers, and some breaths being controlled, then being denoted by their absence of negative inspiratory triggers. In talking about volume and pressure and which one is constant, which one is variable, you can learn a lot by looking at your respiratory tracings. And there are 3 that in specific that you'll want to look at. You want to look at your volume tracing, your pressure tracing, and your flow tracing. So the first example that we'll talk about, let's say we want to have pressure held constant. We're in a pressure control mode of ventilation. And volume is going to be variable. So on time cycled, pressure limited. What you're going to find is that your pressure, in theory, should look somewhat square-like. Right? The breath is going to go on. It's rapidly going to go up towards the pressure that it wants, and it's going to not exceed its limit. Okay? As a result, you're going to find that the flow should trend downward. So as you take a breath, you expand your chest, you run out of room, the pressure gets higher and higher and higher. To maintain this pressure flat, I'm going to have to slow down the rate in which air is going in. And the more or the less compliant your lung is, the steeper this downward graph of flow is going to be. As a result, what you're going to see is that your volume is going to start off with a very high slope here, and as the flow goes down, that slope is going to lessen until you reach expiration. Okay? Now conversely, let's take a scenario where I'm going to hold a volume as a constant and pressure will be variable in that specific setting. In that case, your flow is probably going to be the more square of the wave. Okay? The rules of the game are that I'm going to put in a certain amount of volume, and that's what's going to cycle my breath, that's what's going to terminate inspiration, and that's going to be based upon my rate and my I to E ratio. And so for that amount of time when the flow is being inspired, you should have a relatively sort of straight volume curve. And what you're going to find is that your pressure will go up, right? As this volume enters the chest, and the chest expands and runs out of room, and the pressure goes up in that case. So these are stylized, and there are different ways of modifying how they're delivered if you want an ascending or descending curve. But for the basics of just understand that depending on which one you held constant, this is constant, it's going to affect how your flow appears. You know, is your flow going to be constant? Is your flow going to be variable? So how do we apply assist control clinically? So let's take a patient who has a level of sedation where at the top you have the greatest amount of sedation, you're sedated and paralyzed, and on the bottom you have no sedation. In fact, you're awake and agitated. And we'll look at this spectrum of sedation, and we'll see how many controlled breaths and how many assisted breaths we will be getting in each scenario. So if I have a patient who is sedated and paralyzed, well, they're not going to be able to generate a negative inspiratory trigger, and they will receive 12 controlled breaths if I set my rate at 12. If I remove my paralytic, but they're still pretty heavily sedated, I'm probably going to have mainly controlled breaths, and I may have the occasional assisted breath. As the sedation is lightened, you will find that the proportion of assisted breaths will increase until you reach the point where you are comfortable on the vent and lightly sedated enough such that all of your breaths will be assisted. If I'm awake and agitated, again, I will have 12 assisted breaths, but because the rule only states a minimum, it doesn't state a maximum, I will have above that the number of mechanical ventilated breaths that I attempt to generate. You could see that the patients who are listed in white, assist control would be a good choice of a mode for ventilation for these patients. And the one patient in red, the awake and agitated patient, assist control would probably not be the best mode of ventilation for this patient. as they would have significant hyperventilation. Each additional breath that they would attempt to take would represent a full mechanical ventilated breath. Because assist control is such a low work mode of ventilation, it is good for the initiation of mechanical ventilation. You can have a patient who is sedated and paralyzed, and they will successfully be ventilated with 12 controlled breaths. It is also good for long-term ventilation, and it is important to know that sometimes if a patient is fully sedated or sedated and paralyzed such that they are only receiving controlled breaths, sometimes this is called CMV, or complete mechanical ventilation, meaning that the machine is doing all of the work. It's starting the breaths, and it's delivering the breaths, and it's stopping the breaths. The next mode of ventilation that we'll talk about will be synchronized intermittent mandatory ventilation. And again, the characteristics of the mode is all in the name. The first rule is that the set rate, which is usually an intermittent rate, will be the number of mandatory breaths that is given. In between, the patient will have a patient-determined breath rate, meaning that they will set their own spontaneous breath rate. Rule number 2 is that all breaths must follow either an assisted or an unassisted breath scenario. And the assisted breaths will be the intermittent mandatory mechanically ventilated breaths, and the spontaneous breaths will be the unassisted breaths in between. Rule number 3 is that the mechanically ventilated or the assisted intermittent breaths will be delivered by either volume cycled or time cycled breath types. So you can have volume SIMV or pressure SIMV. Before the advent of synchronized intermittent mandatory ventilation, there was plain intermittent mandatory ventilation, and toggling between the two slides, you can see the slight difference, and it is that the intermittent breaths, instead of being assisted, are controlled, meaning that they are not synchronized. They do not wait for a negative inspiratory trigger from the patient. The danger in this mode being that if an intermittent rate of 4 breaths per minute or a breath every 15 seconds is set, the possibility of the patient having just finished a spontaneous inspiration and now having a mechanical inspiration laid on top of it can lead to volume or barotrauma, or if the patient is attempting to exhale while the 15-second mark is hit and the ventilator attempts to give a breath, you can have dysynchrony and high pressures for that reason as well. By making the mandatory breath assisted rather than controlled, you add synchronization to the mode. Because the mode relies on spontaneous breathing in between the mechanical ventilated breaths, the risk of the mode is hypoventilation. And on the bottom, we can see an example of SIMV, where the mechanically ventilated breaths have negative inspiratory triggers and there is spontaneous breathing in between. And then IMV, where there is no negative inspiratory trigger, and the timing of the mechanical ventilated breath may be problematic depending on the spontaneous breathing in between. So let's again take the same spectrum of sedation for patients. Let's say we have a sedated and paralyzed patient, a lightly sedated patient, an awake and comfortable, and an awake and agitated patient. Here you can see less of these patients are listed in white, meaning that less of these patients are good or ideal candidates for this mode of ventilation. If I have my SIMV set at or my IMV set at a rate of 4, and I have a sedated and paralyzed patient, if I am an SIMV, I would in theory have no breaths. If I am an IMV, I would only have 4 breaths. Either way, you would be hypoventilating. If I am heavily sedated, you would find that I would likely get my 4 breaths if I were in SIMV, or you definitely would if you were in IMV. However, you would probably have inadequate spontaneous respirations in between. As sedation is lightened, the risk of hypoventilation becomes less, and lightly sedated patients are ideal candidates for SIMV. Awake and comfortable as well. You would get your 4 mandatory breaths that are set, and then you would breathe spontaneously in between. Again, awake and agitated is not ideal, but in this case, it's better than assist control at least. In this case, if you were to hyperventilate, you could still obviously breathe above the set rate. However, not every breath attempted by the patient would correspond to a mechanical ventilated breath. So the hyperventilation would be somewhat less. Initially, synchronized intermittent mandatory ventilation was used as a short-term weaning mode of ventilation, It's not the best for long-term weaning because it is a high work mode of ventilation. If you look, while 4 breaths have either very little or no work associated with them, if they are delivered via an assisted or controlled method, the breaths in between have the highest amount of work that are possible. They are spontaneous or unassisted breathing. And breathing through an ET tube is actually more difficult than breathing through your natural airway. And again, it goes back to the fact that your airway resistance is equal to 1 divided by the radius to the 4th power. The airway of an ET tube is much smaller than the airway of your hypopharynx, of your mouth, of your nasal passages. So the resistance is more and the work is more. So for that reason, it is a short-term mode of ventilation. And traditionally, a cardiac surgeon would come out with a first case, put them on the SINV of 10, and say decrease the intermittent rate by 1 breath every 15 minutes as the patient wakes up. And then at the end of their second case, they would come back to the ICU, check on them. They'd be on an SINV of between 2 or 4 and breathing spontaneously in between and ready to extubate. You will find that people will use SINV as if it were assist control. They will set the intermittent rate at a normal physiologic rate rather than a true intermittent rate, with the preference that, unlike assist control, if they were to hyperventilate, they would only hyperventilate spontaneous breaths rather than mechanically ventilated breaths. The next mode of ventilation that we'll talk about is pressure support. And pressure support is the only mode of ventilation that uses flow cycle breath types, and flow cycle breath types are uniquely associated with pressure support. So for flow cycle breath types, it is the inspiratory flow rate that terminates inspiration. The ventilator will sense the initial inspiratory flow rate, and as that flow rate decreases, once it reaches 25% of its original flow rate, assistance will then be terminated with the breath. Again, this is done so in the presence of a pressure limit. Again, because this flow cycle breath type is pressure limited, it is associated with a risk of hypoventilation as compliance changes pathologically in patients. For pressure support, your 3 rules are going to be that for your rate, the rate is going to be patient determined, which means that you need a patient who is able to generate their own sufficient physiologic respiratory rate. All breaths are going to be assisted, which means that if they attempt to breathe, the machine will assist them. There's no unassisted breathing in pressure support, unlike in IMV or SIMV. There is also no controlled breaths, which means that there is no safety backup. If the patient becomes apneic on the ventilator, then they will not receive breaths. And the third rule is that all breath types in pressure support are flow cycle breath types. So again, on the bottom right, you can see that there is an example of a respiratory waveform. The shape is slightly different, and again, it just represents the characteristics of this mode of ventilation. There is, associated with every breath, however, if you notice, a negative inspiratory trigger, which means that the patient is starting each breath, and then the machine takes over and helps and terminates the breath based upon the flow rate. If we take our same spectrum of sedation, we can see that even less patients are listed in white and much more are listed in red, meaning that this mode of ventilation is for a more select population. If you are sedated and paralyzed, and you are on pressure support, you will get 0 breaths per minute because it is a patient-determined rate, and every breath is assisted, meaning the patient needs to generate the breath, and if they're paralyzed, they can't. As they are heavily sedated, they're likely to have none to a few breaths. It depends on how sedated they are. If they are lightly sedated, they may have varying degrees of hypotension, and as you become more awake and comfortable, it becomes a good mode of ventilation for that type of patient. Again, if you are awake and agitated, you will hyperventilate. However, you will not hyperventilate to the same degree as if you were receiving a volume cycle or a time cycle pressure limited breath type. Pressure support is good for weaning and is good for long-term weaning, and it is also used for maintenance of patients who are awake, alert, comfortable, and strong on the ventilator. So if you remember your breath types, your breath scenarios, and your rate options, and you mix and match your choices, you can build different modes. And the most common and most basic modes that you will see will be assist control and its 2 subsets, volume control and pressure control. And if they're fully supported without any assist, it would be called, again, complete mechanical ventilation. IMV and SIMV, and again, you really won't see IMV used anymore. It's all synchronized now. And pressure support. And from these modes, you will have a strong enough basis to develop an understanding of more complex, more advanced, and newer modes of ventilation. There is another way of looking at it. You can think of your breaths delivered by mechanical ventilation as having three characteristics to them. What is initiating the breath, in which case, what is the breath scenario? What is limiting the breath? And what is cycling or stopping or terminating the breath? So your options for breath scenario or initiating are going to be time or pressure. If you are time triggered, it means that you are in a controlled mode. And the initiating factor for your breath scenario is the rate that you set. If you set a rate of 20 every 3 seconds, you will have a breath. The other option for the initiation of breath scenario is pressure, in which case the patient needs to generate a negative inspiratory force that can then be measured by the ventilator, which will trigger it to initiate its support of ventilation. For alarm limits, there are two types of alarm limits. You can either have a volume limit or a pressure limit. And again, if volume is held constant, you will have a variable pressure depending on the patient's compliance. And if pressure is held constant, you will have a varying volume depending on the patient's compliance. And then the last characteristic is cycling, what is terminating the breath type. And your choices are volume, pressure, time, or flow rate. If you use volume as your cycling mechanism, a breath will be given until a preset tidal volume is achieved. If pressure is your cycling mechanism, a breath will be continued until a preset pressure is achieved. If time is your cycling mechanism, a breath will be continued until a predetermined time interval has passed, which will be based upon your rate and your I to E ratio. If flow is your cycling mechanism, a breath will be continued until flow rate declines to a specific point. So if we take a moment and look at some of the more common modes of ventilation that we might use, if we look at someone who is in pressure control, their initiation is either going to be time or pressure, meaning that they're either going to be receiving controlled or assisted breaths depending on their level of sedation. They are going to be limited by pressure, and they are going to be time cycled. If we were to use a volume control, their initiation would be the same, but their limit would be volume and their cycle would be volume. And for someone who is in pressure support, their initiation would be pressure because all their breaths would be assisted. Their limit would be pressure, meaning they're going to have variable volumes, and they would be flow cycled. Here we have examples of different tracings. Up top we could see unassisted breathing or spontaneous breathing, and then the two types of mandatory breathing, assisted breaths and controlled breaths. Again, the assisted having the negative inspiratory trigger. Below it we see a longer example of spontaneous ventilation, and below it is spontaneous ventilation with CPAP applied. Again, the whole inspiratory and expiratory process is raised by the level of centimeters of water of CPAP that are applied. Next to it, we can see assist control and then assist control with PEEP applied. It's an analogous concept in that the whole inspiratory and expiratory process is raised up by the level of PEEP that is applied. To the right of that, you can see a controlled mechanical ventilation where there are no negative inspiratory triggers. Below that is an example of pressure support ventilation. And on the bottom, we have an example of, first on the left, IMV, where the intermittent breaths do not have negative inspiratory triggers, and SIMV, where they do. It is very common to help overcome the increased resistance associated with endotracheal tubes to apply pressure support to the spontaneous breaths in between the intermittent breaths in intermittent mandatory ventilation. So you can see on the bottom what is really SIMV plus PSV. So the modes in some ways can also be added to each other and mixed and matched to overcome certain issues. Moving away from modes, we need to talk about initiation, discontinuation, and maintenance of mechanical ventilation. And you'll find that some institutions will have respiratory therapists that are very protocol driven and will not need initial mechanical ventilation parameters set by you. And some institutions will be very hierarchical, and the respiratory therapist will require every parameter set by you during the initiation of mechanical ventilation. Either way, you should be familiar with these settings. The mode you want to select is assist control, and you want to do this because, again, it is a low work mode of ventilation, and it can be used in patients who are heavily sedated and paralyzed, which if they've been recently intubated may be the case. You want to set your respiratory rate, and if they're breathing spontaneously and they are doing an adequate job of maintaining their physiology, which often is not the case when someone is emergently intubated, you would set their rate to 2 or 3 breaths per minute below what their normal breathing rate is, and this is to account for the fact that the mechanically ventilated breaths will be larger than their spontaneous breaths. But really, you want to set your respiratory rate and your tidal volume because the product of the two of them is your minute ventilation, and your amount of ventilation is what determines what your PCO2 and resulting pH are going to be. So you want to base it based upon your patient's physiologic needs, and generally you want to have a minute ventilation of around 6 to 8 liters per minute. For your tidal volume, if you're using a volume cycle breath type, you would set the volume itself. And again, generally a volume for an adult would be between 5 to 8 milliliters per kilogram. If you're using a low tidal volume strategy, you may go as low as 3 to 5 milliliters per kilogram, and sometimes patients who need to be acutely hyperventilated may have higher volume needs. If you are setting a patient in pressure control, you would simply titrate the pressure limit to obtain the desired tidal volume. FiO2 should initially be set at 100 and then slowly taper down with the goal of an FiO2 of 0.35 while maintaining an oxygen saturation of at least 92%. PEEP is usually set at 5 centimeters of water, and it is uncommon for it to exceed 15 centimeters of water. Keep in mind that when a patient is not intubated, they have a certain amount of natural or physiologic PEEP, and this is generated by back pressure from natural anatomic structures such as the glottis, the tongue, the teeth, and the lips. When an ET tube is placed, these anatomical structures are bypassed, and this physiologic PEEP is lost. To recreate this, almost all patients are usually kept on 3 or 5 centimeters, more commonly, of PEEP. Going too high with PEEP can cause hemodynamic compromise and shunting. The inspiratory flow rate is often set at a default setting and is rarely requested as an initial setting parameter, although it is important to review it. And your IDE ratio is typically going to be between 1 to 2 and 1 to 2.5, with longer expiratory phases for patients who are asthmatic or have COPD. For discontinuation of mechanical ventilation, there are certain musts and there are certain shoulds. So patients must be hemodynamically stable. They must be able to sustain a minute ventilation, which can support them physiologically on a minimal amount of pressure support. And they have to have adequate arterial oxygenation, meaning a PaO2 of at least greater than 60 with minimal support, and minimal support being an FiO2 of 0.5 or less, and PEEP of 5 or less. And if you think about it, in order to be extubated, you have to not have an indication for intubation. So if you were having either hypercapnic or hypoxic respiratory failure, then you would likely need to be intubated. So if you were to intubate a patient, you would not extubate a patient who is in the same physiologic status. The shoulds, your patient should be either negative in volume status or euvolemic, and this is because of the physiologic changes that occur when changing from positive to negative pressure inspiration. You will find that the patients will have an increase in preload when positive pressure is removed from the chest. Fluid has an easier time returning to the chest. And you'll have a functional increase in afterload and decreased cardiac output. The result is that the patients will tend to have more pulmonary edema. So a lot of times patients will be ready for extubation, and it may be held off to allow for several hours of diuresis, with the understanding that when the patient transitions from positive to negative pressure ventilation, their pulmonary edema would increase without that diuresis. If your patient meets these basic criteria, you can then obtain weaning parameters, and weaning parameters give you negative predictive value, meaning that if you do not meet your weaning parameters, you are likely to fail your extubation. However, if you do meet your weaning parameters, it does not necessarily mean that you will succeed. You can still fail. So the parameters that you look at are your PaO2 FiO2 ratio, and this tells you the amount of shunting that is going on in your pulmonary vasculature. And a normal PaO2 FiO2 ratio for an adult would be greater than 400. If it is less than 200, then you have a high amount of shunting. You want to look at their tidal volume, and again, you want to have a normal 5 to 7 cc's per kilogram. The meaning threshold would be about 5. The respiratory rate, and a normal respiratory rate between 14 to 18 respirations per minute. You want the patient to have at least less than 30 respirations per minute, and your minute ventilation. And you want the patient to have a normal minute ventilation such that they can meet their physiologic demands. The two parameters that have the greatest negative predictive value are your NIF, or your negative inspiratory force, and your rapid shallow breathing index, or your RSBI. And for your negative inspiratory force, this is achieved by having the patient attempt to draw in or to inspire against a closed valve and measuring how much pressure they can generate. And you want them more negative than negative 25. So negative 30 would be better, negative 35 or negative 40. But a NIF of negative 10 would not be very good. It's not a strong enough negative force. The rapid shallow breathing index is your respiratory rate divided by your tidal volume. And again, a high numerator or high respiratory rate or a low denominator or low tidal volume, either of those will give you a high quotient or rapid shallow breathing index. And this represents the quality of breath that you're taking. Are you taking long, slow, effective, deep ventilating breaths, or are you taking very shallow, quick breaths where air is really only moving in the transmitting airways and not to the respiratory airways and alveoli? You want your rapid shallow breathing index to be less than 100. The weaning parameters are very dependent on the respiratory therapist obtaining them and their ability to educate the patient and have the patient be comfortable, calm, and cooperative when they're being obtained. So they can be very user determined, meaning you can have poor weaning parameters if the process is rushed or done inappropriately, and be led to believe falsely that the patient has a high likelihood of failing. As such, you should always try and do a spontaneous breathing trial or a T-piece trial. And this will give you positive predictive value, meaning that if you successfully pass your T-piece trial, that the likelihood of you successfully staying extubated would be higher. And you do this by placing the patient on a T-piece or minimal support, just enough to overcome the resistance within the airway of your ET tube and associated ventilator tubing. And you leave the patient on this spontaneous breathing mode for a specific amount of time, after which you check an ABG to ensure that the patient is meeting their oxygenation and ventilatory needs. If the patient has been intubated for a long time and there is a risk of tracheal edema or tracheal stenosis, you may also need to do a cuff leak test, meaning that you deflate the balloon on the ET tube cuff and listen for air moving around the tube. And if you hear air moving around the tube, that is good. That means that there is not swelling within the airway. If you do not hear air moving around the tube, it means that the balloon has been deflated and now their airway has swollen around the tube, such that there's an airtight seal around the tube. And if the tube is then removed, the likelihood of the swelling continuing and the patient's airway becoming compromised is high. And if the tube cannot be reinserted, the patient has a critical airway situation at that point. For maintenance of mechanical ventilation, things that you want to check each day are your patient's FiO2. And we care about their FiO2 for several reasons. One is because high levels of FiO2 will lead to accumulation of free radicals, and also because high levels of FiO2 will actually end up causing ARDS. If you take a rat with perfectly normal lungs and put them on 100% oxygen, within 48, 72 hours, they will go into ARDS. And it has to do with the partial pressure of gases, the flushing out of nitrogen within your alveoli, the drying up of surfactant and decrease of surface tension on the alveoli, and the opening and closing of the alveoli with each breath causing atelectotrauma, which will lead to ARDS. So you want them below 0.5 on their FiO2 as quickly as possible, and you really want them as low as possible while maintaining adequate oxygenation. You want to look at their continuous SpO2 monitor and make sure that their oxygen saturation as well, and periodically correlate this with ABG, PaO2 as needed. You want to ensure that their minute ventilation as well as adequate to maintain their PCO2 and their pH. Each day you want to check your chest x-ray to ensure that your ET tube has not migrated, and because of the high risk of ventilator-associated pneumonia and the frequency of pneumothoraces associated with mechanical ventilation. ABGs should be checked anytime there's a setting change on the ventilator or anytime there's a change in clinical status within the patient. Regular patient ventilator interaction checks and insurance of synchronization with the ventilator is important. If you are in a volume cycle breath type mode of ventilation, it is important to look at the peak inspiratory pressure and inspiratory plateau pressure, and we will talk more about these on the next slide. It is important also to calculate and look at your resistance and compliance to yield information about the status of your airways and your lung parenchymal tissue itself. Ventilator alarms should be checked to ensure that they are set correctly, and routine vital signs should also be monitored as changes in ventilation and dyssynchrony with the ventilator and auto-PEEP and other ventilator-associated problems can lead to hemodynamic changes. In the evaluation of patients who have hypoxia, if they are in a volume cycle mode of ventilation, you can allow the patient to take a breath, obtain a peak inspiratory pressure, and then perform an inspiratory pause, which will yield you an inspiratory plateau pressure. And from these two numbers and the absolute values of them, the peak inspiratory pressure, again, which is representative of resistance and compliance, and their IPP, or their inspiratory plateau pressure, which is representative of compliance only. And the relative difference between the two of them, PIP minus the IPP, representing resistance isolated. The source of hypoxia can be attributed to either resistance or compliance problems or both, and a differential diagnosis can be built accordingly. When you're performing an inspiratory pause as a method to assess pressures and to aid with your diagnosis of a particular hypoxic problem, you can end up with several scenarios. So remember the components of your breath. You're going to take a breath in, reach your peak inspiratory pressure, hold your breath, and then you'll have your inspiratory plateau pressure, and then you exhale, right? You have your inspiration, your inspiratory plateau, expiration, and expiratory pause, all right? Now, the first scenario, let's say, is going to be high resistance. In that case, what you're going to find is that you have a very high peak and then a very big difference and a normal plateau. So your inspiratory plateau is normal and your peak inspiratory pressure is high. In this case, the elevated PIP is due to resistance alone. Because your IPP is normal, your compliance is normal. But the difference between your PIP and your IPP is larger than normal, so you know that you have a resistance problem, you have bronchospasm or whatever. If the case is that you have both high IPP and high PIP, in this case, this is elevated and this is elevated. But the way that you know that it's solely due to compliance is because the difference between the two is not abnormal. So this peak inspiratory pressure has to elevate as your plateau pressure elevates. You can't have a peak less than your plateau. So this gets pushed up as your compliance goes down, but as long as the difference between the two is not great, then you do not have a resistance problem. So this is a compliance issue. The third possibility is you have a high peak and a high plateau. So here's your high peak pressure, here's your high inspiratory plateau pressure. Let's say normal inspiratory plateau pressure is here. So we know that our compliance is bad because our plateau pressure is high, but we know our resistance is bad because the difference between the two is high. And so you can have a high peak but not necessarily have a resistance issue as long as the distance between your peak and your plateau are not great. If it is great, then you have both the resistance and the compliance problem. Obviously, the last scenario would be that you could be hypoxic and have a normal peak and a normal plateau, in which case you probably have an extra pulmonary or maybe a pulmonary vascular, such as pulmonary embolism, source of hypoxia. But by looking at these numbers, you can tailor what your differential diagnosis is. So in the first scenario, if you have a patient who has an elevated peak pressure but a normal plateau pressure, you know that the elevation of their peak pressure is due solely to increased airway resistance. And your differential diagnosis is not limited to, but is likely to include obstruction within the ET tube, mucus plugging, bronchospasm, aspiration, and the treatment for which may be suctioning out the ET tube, or if it is circumferentially caked with mucus and permanently narrowed, it may need to be replaced. Suctioning can relieve mucus plugging, nebulizers can help with bronchospasm, and aspiration would need supportive care as well. If you have an elevated PIP and an elevated IPP, but the difference between the two is not abnormal, then the elevation of your airway pressures is due to decreased compliance. And again, remember the three factors that contribute to compliance, which is distensibility, stiffness, and elastic recoil. And the differential diagnosis, again, will not be limited to, but may include abdominal distension, which would put upward pressure on your diaphragms and limit the distensibility of your pulmonary cavity. And this would be treated with an NG tube. And it is unfortunately not uncommon to sometimes have patients who are intubated because of hypercapnia who really needed an NG tube and decompression to allow them to ventilate adequately. Asynchronous breathing on the ventilator will lead to increased stiffness and decreased distensibility as well, affecting compliance, and this may be treated by changing the ventilator modes or increasing the sedation if need be. Atelectasis is very common and can be treated by re-recruitment with increasing PEEP. Auto-PEEP is a problem which we will talk about on the next slide. Its best treatment is to decrease respiratory rate. A pneumothorax will decrease distensibility within the lung, and the treatment for which would be needle decompression followed by a chest tube. Pulmonary edema would increase the stiffness and thereby decrease compliance, and would be treated with Lasix. ARDS, again, would increase stiffness, and would be treated with a low tidal volume ventilation strategy. And pneumonia would be treated with antibiotics, and again, it would increase stiffness and decrease compliance. If you find that your peak inspiratory pressure is low, then you have decreased resistance. This is usually due to a tubing air leak or a cuff leak at the ET tube site. And this may require the replacement of ventilator tubing or reinflation of the cuff or replacement of the ET tube if the cuff is broken. You obviously can have causes of hypoxia where the source is extrapulmonary, and in this case your peak inspiratory and plateau pressures will be normal, and you will have a normal resistance and compliance. Examples of these would be a pulmonary embolism or other extrathoracic processes, and these patients would require supportive care. You can also perform an expiratory pause, and the reason why you would perform one is to look for auto-PEEP. And auto-PEEP is what is called breath stacking. It is also referred to as intrinsic PEEP, inadvertent PEEP, or occult PEEP. And it is common when the exhalation time is too short for a particular patient. Each previous breath is not fully exhaled before the next breath is given, and residual volume continues to grow until hemodynamic compromise is reached. The best way to treat this is to decrease the respiratory rate, and by doing so, you will be increasing your expiratory phase. With your ITE ratio, your inspiratory time is actively determined and your expiratory time is passively determined. So if you have 10 breaths per minute, you would have a breath every 6 seconds. And if you have an IDE ratio of 1 to 2, you would have an inspiratory time of 2 seconds and an expiratory time of 4 seconds. If you were then to decrease your rate from 10 breaths a minute to 6 breaths a minute, you would have a breath every 10 seconds. The inspiratory time would still be 2 seconds. However, now the expiratory time, which is determined passively, would be 8 seconds, which in this extreme example demonstrates the point that by decreasing the rate, you significantly increase your expiratory time. Other ways of dealing with auto-PEEP are to decrease your tidal volume, to decrease your inspiratory time, or alter your ITE ratio, or to increase your inspiratory flow rate and alter your ITE ratio in that way. Again, decreasing the respiratory rate is the most effective way to correct for auto-PEEP. If you do have a patient who is auto-PEEPing, and specifically if they are in a hemodynamic compromise, it is best to detach them from the ventilator, have them fully exhale, push on their chest if need be, and then manually bag them at an appropriately slow rate until they stabilize, and then reattach them to the ventilator with corrected settings. When you are troubleshooting the patient who is on a ventilator, remember your ABG is going to yield your pH, your PaCO2, your PaO2, your SpO2, and your bicarb, and that you can have one of two main respiratory problems, hypoxia or hypercapnia. Hypoxia would be a low PaO2, and this would be treated by increasing your FiO2 or increasing your mean airway pressure. And the best way to increase your mean airway pressure is by increasing your PEEP. So much so that most textbooks will simply list PEEP as the second option. Hypercapnia or increased PaCO2 is treated by increasing your minute ventilation, and this can be done by increasing the respiratory rate or the tidal volume. For patients who are not intubated, you can still provide mechanical ventilation. However, it is non-invasive because they are not intubated at that point. So non-invasive positive pressure ventilation comes in two forms, CPAP and BiPAP. CPAP is continuous positive airway pressure, and the pressure applied is what is called EPAP, expiratory positive airway pressure. And EPAP is functionally equivalent to PEEP when a patient is on a ventilator. It is expressed in centimeters of water, and it is used to correct for hypoxia because it will increase your mean airway pressure and time for oxygenation exchange. BiPAP is bilevel positive airway pressure, and it uses both EPAP and IPAP. And here IPAP stands for inspiratory positive airway pressure. And IPAP is functionally equivalent to what would be pressure support if a patient were on a ventilator. And this is expressed in pressure support plus PEEP divided by PEEP. So a typical BiPAP setting would be 12/5. And it does not mean that they are on 12 of pressure support and 5 of PEEP. It means they are on 7 of pressure support and 5 of PEEP. So it is important to know that the numerator is the pressure support level or the IPAP level plus the EPAP or the PEEP level. So just remember when you're talking about your mechanical ventilation and when you're thinking about your modes, remember your breath types, your breath scenarios, and your rate, and by combining them in various ways, you can come up with your modes of ventilation. When you're communicating to your colleagues, generally you will say your FiO2, the mode that you're in, your rate, your PEEP, and your SpO2. And if you have a gas, then your gas parameters. If you have a patient who is in pressure support, remember that is a patient-determined mode. So if I were to be signing out the ventilator parameters on this patient, I would not include the set rate. I would say that they are set at an FiO2 of 100 with a pressure support of 10, PEEP of 5, setting 100%. Their rate is patient-determined and will vary from minute to minute. It would be acceptable to give what the patient's average rate was, but it should be noted that this is the patient's determined rate and not a set rate. So we've talked about basic pulmonary physiology. We've looked at modes of ventilation and their components and how they're put together and how they're used. And we've also looked at initiation, maintenance, and discontinuation of mechanical ventilation. And this basic foundational information is a good starting point as you move forward and expand your knowledge with respect to mechanical ventilation and discuss more complex modes of ventilation such as pressure-regulated volume control, among others. Welcome back. I hope you found the lecture enjoyable and informative. And really, it should set you up such that when you encounter more complicated modes of ventilation, you'll have the basic understanding necessary really to do a little bit of learning on your own and really be able to understand them, interpret them, and utilize them efficiently. But the basics really just come down to airway physics and pressure and volume and flow and time and inspiratory and expiratory times and rate, and how they all mathematically relate to each other and how they physiologically have impacts on the pulmonary system and hemodynamic system. So I hope you've enjoyed this and you can apply it right away, and we'll hopefully see you next time. And as always, thank you for your time and interest.